Assalamu alaikum. My name is Dr. Mariam Nasrullah, and today we will discuss a few topics of strabismus. Specific learning outcomes. By the end of this presentation, participants will be able to describe pseudostrabismus, heterophoria, vergence abnormalities, different types of esotropia, and different types of exotropia. Pseudostrabismus. Pseudostrabismus occurs when clinically no squint is present, but there is an impression of ocular deviation. It occurs in various conditions. For example, if a patient has epicanthal folds, if there is abnormal interpupillary distance, if the interpupillary distance is enlarged, there is a false impression of esodiviation. For example, in hypertelorism, the distance between the two orbits is increased and there is enlarged interpupillary distance. In telecanthus, the distance between the two medial canthi is increased, but the interpupillary distance remains the same. Angle kappa is the angle between the visual and the anatomical axis. The visual and the anatomical axes are not the same. Visual axis it is an imaginary line that passes from the center of the cornea to the fovea, whereas the anatomical axis is a line which passes from the center of the cornea to the posterior pole. This is the picture in picture A. Pseudo esotropia is seen because of the epicanthal folds, and in picture B, there is wide interpupillary distance which simulates exotropia. Normally, angle kappa is positive, which is 5 degrees, and the fovea is situated just temporal to the anatomical axis. To achieve the bifoveal fixation, eyes are slightly abducted, and the corneal light reflex is just nasal to the center of cornea. If the macula is displaced temporally, there would be large positive angle kappa, and there is pseudo exotropia. And if the fovea is situated nasal to the posterior pole, there would be negative angle kappa, and it will simulate esotropia. Pseudo esotropia will occur. In the first picture shows a normal angle kappa of 5 degrees. In picture B, there is pseudo exotropia because of large angle kappa, large positive angle kappa. And in picture C, there is negative angle kappa simulating an esotropia. Heterophoria. Heterophoria is the tendency of the eyes to deviate when fusion is blocked. In heterophoria, fusion amplitudes are insufficient to maintain alignment, and it usually presents at the times of stress and poor health. Signs: esophoria and exophoria can be classified by distance at which angle is greater. There can be convergence, excess or weakness, divergence, excess or weakness, or it can be mixed. Treatment of heterophoria is orthotic exercise. For exophoria, refractive errors should be corrected. Temporary stick-on Fresnel prisms are available, which are sticked on to the posterior surface of the glass of spectacles, and if they are tolerated well, they are later incorporated into the spectacles. Maximum 10 to 12 prism diopters are incorporated, and they are split between the two eyes. If deviation is larger, surgery is recommended. Vergence abnormalities. Vergence is a movement of two eyes in the opposite direction. There is convergence insufficiency, divergence insufficiency, near reflex insufficiency, and spasm of the near reflex. First, we will discuss convergence insufficiency. It affects individuals with high near visual demands like students. Signs are a remote near point of convergence greater than 10 cm, Normal near point of convergence is 6 to 10 centimeter, and there is poor fusional convergence amplitude. Near point of convergence is the maximum convergence, which is the distance for maximum convergence. Treatment is orthoptic exercises and base in prisms. Accommodative insufficiency, it may be idiopathic or post-viral. It affects school-age children, and minimum reading correction is given for accommodative insufficiency. Divergent insufficiency. There is reduced or absent divergence fusional amplitudes. It is usually associated with an underlying neurological condition like intracranial space-occupying lesion, head trauma, cerebrovascular accidents. It can present at any age, and it is difficult to differentiate from 6 nerve palsy. It is treated with prisms. Near reflex insufficiency. There can be paresis of near reflex insufficiency or paralysis. In paresis, it presents as dual convergence as well as accommodation insufficiency, and on attempted near fixation, mydriasis occur. Treatment is reading glasses, base in prisms, and botulinum toxin. In complete paralysis, convergence or accommodation neither can be initiated. There may be functional origin or midbrain disease, head trauma, and recovery is possible. Spasm of near reflex. It is a functional condition affecting patients of all ages, usually female. Symptoms are diplopia, blurred vision, and headache. Signs are esotropia. There is pseudomyopia. Pseudomyopia is confirmed through refraction with and without cycloplegia. Meiosis is the key to diagnosis, and spasm is triggered when testing ocular movements. In picture A, there is occlusion of the right eye. The spasm of the near reflex is precipitated on testing the ocular movements, and in B there is right esotropia and meiosis, which is the key to diagnosis. Treatment is reassurance and telling the patient to not initiate any activity which trigger the response, atropine, and full reading correction. Esotropia. Esotropia is an inward deviation of eye. It is also called manifest convergent squint. It can be concomitant or incomitant. Concomitant is the variability of angle of deviation is within 5 prism diopter in different horizontal gaze positions. And in incomitant, angle differs in various positions of gaze, and it is due to abnormal innervation or restriction. Classification of esotropia. It can be either accommodative and non-accommodative. In accommodative, it can be due to refractive cause or non-refractive cause, and the various causes of non-accommodative are early onset, microtropia, basic, convergence excess, convergence spasm, divergence insufficiency, divergence paralysis, sensory, consecutive, acute onset, and cyclic. Early onset esotropia. It is also called congenital and essential infantile. It is idiopathic esotropia which manifests within the first 6 months of life. There is no significant refractive error and there is no limitation of ocular movements. Signs. Angle of deviation is greater than 30 prism diopter. There is fixation alternating in primary position. Cross fixation on side gaze. For example, if the patient is looking on the right side, the left eye will fixate, and if the patient is has looking on the left, the right eye will fixate, and if the patient is looking at right, on left, the right eye will fixate. False impression of abduction deficits like bilateral 6 nerve palsy, abduction demonstrated by doll's head maneuver or rotating the child, unilateral patching, unmasked ability of other to abduct. In alternating fixation in early onset esotropia is seen, and picture B shows fixating of the left eye. In picture A, there is fixation of the right eye, and in picture B, there is fixation of the left eye. This picture shows cross fixation in early onset esotropia, left fixation on right gaze and a right fixation on left gaze. Other signs are horizontal nystagmus. Latent nystagmus is seen when one eye is covered and fast phase beats towards the side of the fixing eye. And manifest latent nystagmus is seen with both eyes open, and on covering one eye, amplitude of nystagmus increases. A refractive error of about +1 to +2 diopter is there. There is asymmetry of optokinetic nystagmus. There can be inferior oblique overaction, and a dissociated vertical deviation is also seen in 80% of the patients at the age of 3 years. In this picture, we can see bilateral inferior oblique overaction. In picture A, there is the eyes are straight in the primary position, and on right gaze, the left inferior oblique overaction is seen, and on left gaze, the right inferior overaction is seen. Inferior oblique overaction is seen. This picture shows dissociated vertical deviation. The eye under cover is dissociated moved superiorly. There is an updrift of the eye under cover. In picture B, there is left eye which is undercover and it is up. It has gone upward, and in picture C, there is the right eye is undercover and there is updrift of the right eye. Differential diagnosis: bilateral congenital sixth nerve palsy, secondary esotropia, nystagmus blockage syndrome, Duane syndrome, Mobius syndrome, and Strabismus fixus. Initial treatment should be there should be surgically corrected by the age of 12 months to 2 years, and amblyopia and significant refractive errors should be corrected first. Surgery before 12 months of age gives superior sensory outcome. Procedure is there can be recession of both medial recti or unilateral medial rectus recession with lateral rectus resection. Angles larger than 50 degrees require both medial recti recession with one lateral rectus resection. Recession of more than 6.5 mm of medial rectus leads to overcorrection, and goal is to align the eyes within 10 prism diopters associated with peripheral fusion and central suppression. This is a picture of early onset esotropia before surgery in A and after surgery in picture B. Subsequent treatment, if undercorrection is there, it requires further recession of the medial recti, resection of one or both lateral recti, and surgery of the other eye. Inferior oblique overaction most commonly occurs at the age of 2 years. It is unilateral initially but can be bilateral within 6 months. Weakening procedures are disinsertion, recession, and myectomy. Dissociated vertical deviation is updrift on extorsion of eye under cover. Spontaneously during periods, it occurs spontaneously during periods of visual inattention, and on removing the cover, affected eye will move downward. It is usually bilateral. The treatment is superior rectus recession with or without posterior fixation sutures, resection or tuck of inferior rectus muscle, inferior oblique anterior transposition. Amblyopia can develop in 50% of the cases. Unilateral fixation preference develops postoperatively. Accommodative element should be suspected if the eyes are initially straight after surgery, so regular refraction is important. Next is accommodative esotropia. Near vision involves both accommodation and convergence. Accommodation is the process by which the eye focuses on the near target and the anterior curvature of the crystalline lens is altered. And in convergence, inward movement of eyes is there to fixate bifoveally on the target. The normal the normal ACA ratio is 3:1, And if there are abnormalities of the ACA ratio, they cause certain types of esotropia. Refractive accommodative esotropia. It presents at the age of 18 months to 3 years. The AC over A ratio is normal. Physiological response to excessive hypermetropia. The hypermetropia is between +2 to +7 diopters. And proportionate amount of convergence is present for distant target. Beyond patient fusional divergence amplitude and manifest convergent squint occurs. Deviation varies less than 10 prism diopters between distance and near. It can be fully accommodative or partial accommodative. Fully accommodative hypermetropia with esotropia when a refractive error is uncorrected. Deviation is eliminated with refraction, and a binocular single vision is present at all distances following optical correction. And in partial accommodative, it is not eliminated by full correction of hypermetropia. Myopia occurs in partial accommodative, and there is bilateral congenital superior oblique weakness, suppression of squinting eye, although abnormal retinal correspondence may occur. This picture shows fully accommodative esotropia. In picture A, there is a right esotropia without glasses. And in picture B, the esotropia is corrected, straight eyes for near and distance with glasses. This shows fully accommodative esotropia in a baby. In picture A, there is esotropia without glasses, and with glasses it is corrected, straight eyes for near and distance with glasses. This is partially accommodative esotropia. In picture A, there is right esotropia without glasses, and in picture B, the eyes are not straight but the angle is reduced with glasses. Next is non-refractive accommodative esotropia. In this, the AC over A ratio is high. There is unit increase of accommodation. It leads to disproportionately large increase in convergence. It occurs independently of refractive error, and there is hypermetropia which coexist with it. Convergence excess. High AC over A ratio due to increased accommodative convergence. There is normal near point of accommodation. The eyes are straight with a binocular single vision for distance. There is esotropia for near, usually with suppression. And the eyes are straight with bifocals. This is convergence excess esotropia. In picture A, we can see eyes straight for distance. And in picture B, there is esotropia, right esotropia for near. And in picture C, eyes are straight when looking through bifocal spectacles. The next is hypoaccommodative convergence excess. There is high AC over A ratio due to decreased accommodation. There is remote near point of accommodation, eyes straight with binocular single vision for distance, esotropia for near, usually with suppression. Treatment is first we will correct the refractive error. Cycloplegic refraction for children under the age of 6 years, and above the age of 6 years refraction is without cycloplegia, and bifocals are recommended for convergence excess esotropia. Strength of the lower segment should be gradually reduced and eliminated by early teenage years of bifocal spectacles. Surgery is recommended to restore BSV to improve appearance of squint, and it should be considered only if the spectacles do not fully correct the deviation. Surgery is a bilateral medial rectus recession, unilateral medial rectus recession with lateral rectus resection. If there is residual amblyopia, surgery is done on the amblyopic eye. Medial rectus posterior fixation sutures, also known as Faden operation, can also be done. The next topic is microtropia. Microtropia is a small deviation, small angle which is less than 10 prism diopter. It can be primary or it can be secondary. Secondary develops as a sequelae of strabismus surgery. Symptoms are rare and they may not be readily detected on cover test. There is association with anisometropia, hypermetropia or hypermetropic astigmatism with mild amblyopia. The fusion amplitudes are normal. ARC is present with associated abnormal binocular single vision. Fovea of the fixating eye acquires abnormal common visual direction with extrafoveal location in the deviating eye. Central foveal suppression scotoma occurs in the deviating eye. Treatment is correction of the refractive error, occlusion of the amblyopic eye, occlusion for amblyopia. Occlusion is done on the good eye. Aggressive treatment leads to normalization. Near esotropia, also known as non-accommodative convergence excess. It occurs in older children and young adults. There is no significant refractive error. They are orthophoric for distance and esotropia for near, but the AC over A ratio is normal. The near point of accommodation is normal and treatment is bilateral medial rectus recession. Next is distance esotropia. It occurs in young adults who are usually myopic. There is intermittent or constant esotropia for distance. There is no deviation for near. There is normal bilateral abduction, absence of neurological disease, and treatment is prisms and surgery if the cases are persistent. Acute late onset esotropia. It presents at around 5 to 6 years of age. There is sudden onset of diplopia and esotropia. The ocular motility is normal and there is no significant refractive error. In acute onset esotropia, the sixth nerve palsy must be excluded. Management is check for pupillary reflexes, exclude any optic disc changes, exclude nystagmus and sixth nerve palsy, and treatment is prisms, botulinum toxins or surgery. Secondary, also called as sensory esotropia. There is unilateral reduction in visual acuity that interferes with fusion. The causes are cataract, optic atrophy or hyperplasia, macular scarring, and retinoblastoma. So, dilated fundal examination is must in all children with strabismus. This is a picture of a child with right esotropia, which is secondary to retinoblastoma. Consecutive esotropia, it usually occurs following a surgical overcorrection of an exotropia and it should be corrected within 6 weeks. Divergence insufficiency. It is age-related degeneration of the lateral rectus superior rectus band. It is also called as sagging eye syndrome. There is distance esotropia but no near esotropia. There is limited supraductions of both eyes and ptosis occurs with deep superior sulcus. High myopia esotropia. There is instability of the muscle pulleys that stabilize superior rectus and the lateral rectus. Nasal displacement of the superior rectus occurs and inferior displacement of the lateral rectus occurs. It is considered in high myopia with acquired esotropia. MRI is the key to diagnosis and treatment is plication of the superior and the lateral recti with suture. Exotropia. Exotropia can be early onset exotropia, intermittent exotropia, secondary exotropia or consecutive exotropia. First we will discuss early onset exotropia. It is present at birth. There is normal refraction. There is a large and constant angle. Dissociated vertical deviation may be present and neurological anomalies are frequently present. Treatment is surgical correction with lateral rectus recession and medial rectus resection. Next is intermittent exotropia. It is not present at all times and eyes are straight with binocular single vision at time and manifest exotropia is present at other times. It presents at around 2 years of age, initially with exophoria, and this exophoria is converted to exotropia under conditions of visual inattention, fatigue, or ill health, and bright light. Patients with exotropia, they close their eyes when bright light is shown in their eyes. The control varies with distance of fixation and concentration of patient. This picture shows intermittent exotropia. In picture A, we can see the eyes are straight most of the times, and in picture B, there is left exotropia under conditions of visual inattention or fatigue. Classification is distance axis basic and convergence insufficiency. In distance axis, deviation is greater for distance than for near, and the deviation increases further beyond 6 meters. In basic, control of squint and angle of deviation are same for near and distance fixation, and in convergence insufficiency, deviation is greater for near as for far, and it occurs in older children and adults. Treatment is spectacle correction in myopic patients, part-time occlusion of the non-deviating eye, orthoptic exercises, and if these are not successful, surgery is indicated. In poor or progressively deteriorating condition, unilateral lateral rectus recession and medial rectus resection is done. Exodeviation is rarely completely eliminated by surgery. Next is sensory exotropia. It is also called as secondary exotropia. There is monocular or binocular visual impairment by acquired lesions like cataract, corneal scarring, and media opacities. Treatment is by correcting the visual deficit and surgery. This picture shows left sensory exotropia, which is secondary to corneal opacity. Next is conjunctive exotropia. It develops spontaneously in amblyopic eye. It usually occurs following surgical correction of an ESO-deviation. Treatment is surgical correction of the deviation, and 75% are well aligned 10 years after surgery. References: Kansky, Clinical Ophthalmology. Thank you.
Okay, excellent presentation. Especially you have included the specific learning outcomes. That is a good addition. And by the end of this presentation, participants will be able to describe. Well done. Uh, Good. So, uh, what is the definition of squint? Anybody? बैठ जाए आप. How do you define strabismus or squint?
Deviation of the angle of eyes.
It is misalignment of the visual axis or misalignment of the eyes. So first we rule out the pseudosquint. So telecanthus, distance between the two medial canthi is increased. So what is the normal distance between the two medial canthi? 59 to 60. 30 millimeter. So if it increases beyond, so if it increases beyond 45 millimeter, then this is telecanthus. What is the distance between the two pupils? Interpupillary distance. What is the exact amount? 60 millimeter is the normal distance. So if it increases, then what is the diagnosis? It means the two orbits are separated, or hypertelorism. So telecanthus, what is the normal size of the lid? Horizontal. 25 to 30. Good. So 11-12 millimeter is cornea, and the lid is 30 millimeter. Yeah. So in blepharophimosis syndrome, the lid length decreases, the telecanthus is there. So you should know the normal values also, so that you can label whether it is a telecanthus or not, whether there is hypertelorism or not. Okay, so coming to the squint, so if a patient presents with pseudo squint, let's say there is telecanthus, how will you exclude the strabismus? What would be your next step? The appearances of a squint, hushbug, and cover uncover and alternate cover test. So if the eyes are straight on cover uncover or alternate cover test, that means there is no squint, right? So if there is some problem, let's say thyroid eye disease, first we correct the orbital pathology, then we correct the squint later on, and the lid problem. So there is a sequence in which we correct. Orbital problems are addressed first of all, and then the lid and squint are addressed. Okay, so how do you calculate ACA ratio? What is ACA ratio in simple words? How will you say that the ACA ratio is more? Hmm. But what is your concept that ACA ratio means? What are the sort of clinical feature of high ACA ratio?
Sir, 1 unit of accommodation and it has 3 units of convergence accommodative.
Good, good. So if अगर इससे ज़्यादा convergence होती है accommodation पे high ACA ratio है, so what are the different methods for measuring it? There is a heterophoria method, gradient method, and there are two more methods. So four methods of measuring high ACA ratio. So in one you use different lenses, and in other you use different distances to calculate what is the difference in the squint for far and near, or with glasses and without glasses. So whenever the patient comes to us, we will do the cover uncover and alternate cover test for distance and for near. So how do you measure the convergence point, near convergence point, and the near accommodation point?
If the distance at which the maximum convergence occurs with intact fusion by
Good. But how actually? What is the instrument vision?
कोई भी फिक्सेशन टारगेट को हम मूव करते हैं टुवर्ड्स द नोज और पेशेंट को कहेंगे कि जब तक उसको सिंगल इमेज नजर आ रहा है.
Good. So when you bring a target closer, let's say a pen, and the patient complains of diplopia, it means the convergence, it is more than the convergence area, or the eye goes out. So you know that this is the near point of convergence, but the formal measurement is with Royal Air Force rule. There is a line on the card, RAF rule. और भी इंस्ट्रूमेंट हैं लेकिन RAF सबसे पुराना है. So there is a line on the card, and when you bring it closer at a point where the patient complains of diplopia or the eye goes out, it means this is the near point of convergence. So what is the near point of accommodation? How do you measure it?
accommodation के लिए भी हम फिक्सेट उसे करा के we move towards that और फिर हम उसमें accommodation के components भी होते हैं ऐड करते हैं.
Good.
वो हम देखते हैं meiosis.
Okay. Yeah. So you bring the in RAF again, Royal Air Force rule, you bring the line closer, and where it becomes blurred out of focus, there is near point of accommodation. So there is a difference between the two, near point of accommodation and near point of convergence. So, okay, so what are the different, how do you write esophoria in notes? E, good. And esotropia? ET. And esotropia for near? Dash. So ET dash. Okay. So these are the different signs. So now you should be master in prism alternate cover test. So how do you measure the fusional reserve? What do you mean by fusion or fusional reserve?
Till when we are achieving that binocular single vision, that is.
So if binocular single vision is maintained in in spite of adding prism in front of one eye, that means the it is within fusional range. When the eye deviates, it means it is out of fusion. So we can measure the fusional reserves with the help of synaptophore or with prism bar. See, when we want to relieve the squint with prism, what we do is that the apex of the prism is in the direction of deviation. But if we want to do orthoptic exercises, this is the opposite. In esophoria or tropia, if we want to do exercise, then the apex would be towards temporal side, outside. So prisms can be used in two positions. One, to relieve the squint, and number two, to do the orthoptic exercises, to exercise and increase the fusional reserves. Okay. So Fresnel prisms are very frequently used in West. They have a plastic sheet, and the orthoptist just cuts the Fresnel prism and sticks on the glasses. Easy to use, right? The prisms can be incorporated in the glasses. The opticians do this job. So we write what is the prism diopter to be included, and this can be done with decentration or with the introduction of prism. Inferior oblique overaction can be primary, in which case there is no hypertropia. There is no vertical deviation in the primary position. Or it can be secondary because of the superior oblique palsy, in which case there will be hypertropia, which increases in opposite gaze and ipsilateral head turn. Park's three-step test, Bialchowski's step. So in inferior oblique overaction, the commonest procedure we do is recession. Although a simpler procedure can also be done as myectomy. And if inferior oblique overaction is associated with DVD, then we do anterior transposition. It can be nasal and temporal. In anterior transposition, what we do is that the inferior oblique, which passes in front of the inferior rectus 4 millimeter behind the inferior rectus recession, we bring inferior oblique forward from its position, which is 4 millimeter behind the inferior rectus. So if we bring it at the level of inferior rectus insertion, this is called zero position. If we bring it 1 to 2 millimeter in front of inferior rectus, this is called +1 or +2 position. If we bring it 1 or 2 millimeter behind the inferior rectus, this is called -1 or -2 position. It is still interior sort of transposition, because the normal course is 4 millimeter behind the inferior rectus. Right, so DVD dissociated vertical deviation. So dissociation can be vertical or horizontal or torsional. So there is DVD, DHD, and dissociated cyclodeviation. So if an eye goes out and then come, this is a horizontal deviation. It goes up and down, this is vertical deviation. Similarly, cyclotorsion. In intermittent exotropia, we ask the patient or parents how much time the squint is there. If it is present most of the time, then we do the surgery. Surgery, the maximum amount of deviation which we can elicit. Right? So, any comment, sir?
So, cover and cover test is very important. You have to do measurements तो आपने करनी है। उसके अलावा इम्पॉर्टेंट इस कि आपने कवर एंड कवर पे आपने उसमें हशबर्ग भी इंक्लूड हो जाएगा और कवर एंड कवर, और तीसरी चीज़ जो है वो प्रिज्म के साथ आप प्रिज्म डेविएशन जो है वो मेजर करते हो। तो उसमें यूजुअली कॉमन कौन सी है जो डेविएशन मोस्ट कॉमन? ईज़ोट्रोपिया अमंग्स द किड्स, ठीक है। और ओल्ड एज में जो सेकेंडरी होती है उसमें यूजुअली एक्सोट्रोपिया, ठीक है, बिकॉज ऑफ सेंसरी डिप्राइवेशन, जैसे कैटरेक्ट है, ट्रॉमा हुआ, कुछ और उसमें कॉमन है एक्सोट्रोपिया। तो अकॉर्डिंगली यू हैव टू ट्रीट दोस कंडीशंस। तो स्क्विंट में बात वही आ जाएगी कि क्या करते हैं, ट्रीटमेंट क्या करते हैं। 3 ऑप्शन दी थी आप लोगों ने ट्रीटमेंट की, क्या थी?
इसके अलावा सर्जरी होती है, और अगर आप मायोपिया है तो
पैचिंग, ऑर्थोप्टिक एक्सरसाइजेस, और टेम्परेरी ट्रीटमेंट क्या है वो भी है। उसके अलावा बोटुलिनम टॉक्सिन इन केसेस ऑफ पैरालिटिक, यूजुअली पैरालिटिक स्क्विंट में वो देते हैं। तो ये जो हॉरिजॉन्टल डेविएशन जो है वो ज़्यादा कॉमन, तो उसके लिए क्या करते हो आप? या रिसेक्शन करते हैं या रिसेक्शन। रिसेक्शन में क्या होता है? सो उससे क्या होता है? मसल स्ट्रेंथनिंग। दूसरा क्या है? एक और होती है मायोटमी, मायोटमी होती है, स्प्लिटिंग, ठीक है। और एक क्या होती है? टक इन, टक करते हैं आप, शॉर्टन करने के लिए उसी को उसके ऊपर फोल्ड करते हैं, फोल्ड करके सुचर करते हैं। इंस्टेड ऑफ के लिए आप उसको एक्सरसाइज करके तो रिसेक्शन करें, उसमें क्या करते हैं, उसको लेंथनिंग को शॉर्ट करने के लिए उसको टक इन करते हैं। So these are various options for removing, increasing the length or increasing the power or decreasing the strength. तो ये सर्जरी की प्रिंसिपल है। ये you have been doing, they've been going to the theaters, और वहाँ देखेंगे आपको, वो देखते होंगे कौन कौन जा रहा है थिएटर में, ऑक्यूलोप्लास्टी देख रहे हैं स्किन सर्जरी।
So when we discuss the surgical treatment, see, if there is power in the muscles, we do resection and resection, like horizontal esotropia, exotropia, medial rectus, lateral rectus, resection. But if there is palsy, paralytic squint, then we do not do resection because there is no contraction in the muscle. Then we do transposition procedures. Like in lateral rectus palsy, instead of doing a resection of the lateral rectus, we will do Jensen and Hummelshim procedure. So what is the difference between the two?
इंसर्शन होती है उसको स्प्लिट करते हैं और एक में इंसर्शन को रिमूव नहीं करते और पीछे से ही स्प्लिट करते हैं मसल को और उसको अटैच कर देते हैं लैटरल रेक्टस से और मीडियल रेक्टस।
Good. So if we disinsert the lateral halves of superior and inferior rectus and attach them on the upper and lower border of the lateral rectus, this is called humulcheme. If we split the medial rectus, the lateral rectus, superior and inferior recti into two and then unite the superior half of the lateral rectus with lateral half of superior rectus, and we unite the inferior half of lateral rectus with lateral half of inferior rectus. This is called Jensen procedure. So only splitting is done. Disinsertion is not done. Usually done in older age patients where we are afraid of anterior segment ischemia. Anterior segment ischemia occurs if we disinsert more than two recti muscles. Okay, so similarly for superior rectus malfunction, there is monocular elevation deficiency or previously known as double elevator palsy. What procedures we do? NAP procedure, modified NAP procedure and Callahan procedure. So NAP is like Hummelchim procedure in which we disinsert both the medial and lateral recti and we attach these two along the sides of the superior rectus. And Callahan procedure is like Jensen procedure where we split the medial and lateral recti and the superior rectus and attach the two. So you will study it and then you will become more familiar with it. So the transposition procedures are done when there is paralytic squint. See, in paralytic squint, our aim of surgery is to bring the eyes in alignment in the primary position of gaze. If you can improve the adductions or versions, it is a bonus. But primary sort of aim is to align the eyes in the primary position when the patient is looking straight. You see, uh, usually there is upper limit of how much you can recess. Medial rectus 6 millimeter, lateral rectus 8-9 millimeter. So if you recess more than that, what would happen? Oh, so there will be decrease in the adductions in the direction of action of that muscle. See, if you medial rectus, if you recess more than 6 millimeter, then the adduction will be limited. So you don't want to limit the eye movements. So you don't uh, recess it more than 6 millimeters. But in paralytic squint, you go maximum recession and dissection to pull the eye into straight position in primary position. So there is no limit in the paralytic squints. Okay.